Suicide prevention is basically about how we understand human behaviour. And there's no one way of understanding human behaviour, but there are two ways in which we often do it. One is that we can either use a microscope or a telescope. And there's quite a lot of debate about whether we can understand behaviour best by looking through a microscope or understand it better by looking through a telescope. If we look at it through a microscope, we can get down to the detail of what makes the human body and the human mind tick. And we can narrow it down to molecules and DNA sequences and parts of genes and conflicts and psychological problems and repressed memories through a microscope. If we use a telescope, we get much better at looking at people in the bigger environment that they live in. There's no right or wrong way, because both the microscope and the telescope have been hugely helpful in understanding human behaviour. But there are problems with both of them. If we rely entirely on a microscope, we can sometimes let the detail of what we're looking at obscure the bigger picture. And if we rely entirely on a telescope, we sometimes lose the plot because we get lost in space. Between the microscopic view and the telescopic view, there's what can be called the naked eye view. And that's what most of us rely on. Most of us don't have a microscope handy, nor do we have a telescope handy. We have just our eyes and our ears to go by. And that's quite useful. Of course, you can't see the detail. Our eyes aren't strong enough. Nor can you see out far enough because our eyes aren't far enough. And sometimes our own view of things is coloured by the spectacles that we wear. And all of us wear spectacles of some sort, spectacles that bias us towards a particular view or bias us away from a view. So we can't rely on what we might think is a common sense approach. Why don't we just use our own sight? Because our own sight is always limited. So we've got three options. Use the microscope, use the telescope, use the naked eye. The point I want to make is we put all three together, and we might be able to get somewhere at preventing what we want to prevent. Then there are what could be called suicides that have a pretty strong cultural base. Cultural alienation is a not infrequent problem with young people, and the Maori rates of suicide are much higher in the under 35-year age group than they are in the over 35s. And that may well have something to do with a sense of alienation from two cultures, an alienation from their own culture, and as a result of that, or in association with that, an alienation from the wider New Zealand culture. The other difficulty that sometimes arises for people is a frustrated identity, that they know they should feel a certain way or should have certain knowledge or should act in a certain way, but don't know how to get there. And that leads them to be frustrated about their identity and dissatisfied with their own identity. If we look at suicide prevention from 3 points of view, perspectives on suicide, the levels of prevention, and the types of interventions that will be useful, we can see the perspectives on suicide include the way society operates, the way that the medical perspectives of suicide, the cultural perspectives, and the interpersonal ones. The three levels of prevention I mentioned: primary prevention addressing the whole population, secondary prevention focusing on people who are at risk, more at risk than others, and tertiary prevention, which is about reducing the impact of the event on the survivors. And then the three critical points of, in any intervention, being able to engage with the group you want to engage with in the right way and so it makes sense to them, which is getting on their wavelength, being able to produce some sense of enlightenment so that people come away feeling good and enlightened rather than confused and burdened. And the third point, of course, the aim of the exercise is to empower people, not to forever see ourselves as caring for people.